how can we, oh no, I see a follow-up question to kind of CAR Ts. Is it better to, this is a good question, tough question. Is it better to move cellular therapies earlier up? So, you know, currently in myeloma, it's off clinical study. It's reserved for 4th or 5th line therapy for CAR T is the approval. While in lymphoma, it's approved on various indications, either at first or second, or in some cases, 3rd relapse. So would it be better, you know, why not just do this in all newly diagnosed patients? So anyone in the group, are we studying this now? And what are some pros and cons of that approach? Dr. Rajeeve?
Yeah. So I think there's definitely studying like CAR Ts in the more earlier lines of therapy, because we do have a couple of trials open at my institution. And, you know, there are various arms of that trial, and I think it's encouraging. And I think the dogma of reserving good therapies for later in the line has been challenged, because we want to give patients the best treatment as early as possible. So that's why I think these trials have been designed, and there are certainly many trials ongoing in which CAR Ts are now moved to the, you know, 1st line setting, 2nd line setting, earlier line settings. We should have a readout of these trials hopefully in the next few years, and hopefully myeloma can replicate the ZUMA-7 success that lymphoma had, which actually was CAR Ts the earlier line for aggressive lymphoma. So very hopeful for that.
Yeah, you know, these studies are occurring, and we're gonna continue to try to move up these therapies or combinations of these therapies. Again, it's going to be very important that we show in a well-designed, we have very good outcomes in myeloma right now. We show, and I think it's probably, you know, when we look at moving these therapies up, especially with significant risks, you know, we like to study higher risk patients first who aren't doing optimal with our current approach. So like in lymphoma, we looked at patients who relapsed right away after chemotherapy. And those patients don't do that well with our current approach. And so we moved up CAR T and we've had success. So I think in myeloma with the higher risk, you know, moving those therapies up, but we're still going to have to show, you know, in a controlled fashion that by doing that, it's safer and better, and our patients are doing better with those approaches. So those studies will take time to figure that out. But I'm pretty optimistic of a future that, you know, we're going to be using immunotherapeutics in lymphoma and myeloma with less of, you know, I do transplant. I don't ever need to do another auto transplant again. If we can figure out a way to get rid of it, I'll celebrate that day. And if you ask me now, I truly believe in 10 years, you know, that we will, if you say, what do you predict? I do think that we're going to get there. Just what I've seen since the last 5 years in my practice. I mean, patients, I have this discussion all the time with myeloma or lymphoma. They go, well, what are you going to do when it comes back? And I tell you, I have no idea, because in 5 or 6 years, it's going to be completely different and better. And it's a good problem to have.